Thank you very much. I'm just waiting for my slides. So I will talk about recent trials on microvascular risk in diabetes, focusing mostly on fenofibrate. And I will talk more lengthy about the LENS study, which has been shown last year. So the previous speaker has done a very nice job for me to introduce the mechanism of complications, so I can go directly to my third slide. I will put a lens because the screen is very small. So if one look at the, do I have an arrow? Yeah. These are the Brownlee mechanisms, the 4 pathways that are activated by high glucose, and they tend to produce oxidative stress in not only the retinal cells, but also what we call the neuro. It's a unit called the neurovascular unit of the retina. There are many other cells involved, and this is why the mechanism of diabetic retinopathy is so complex. Irrespective of that, what is very clear is that retinopathy in diabetes is the clearest form of microvascular damage because it's only caused by high glucose to start with. Now, we have very efficient treatment for advanced retinopathy. These are mostly injectables, but also we have simple oral drugs which have shown evidence, even though it's still off-label in many countries, but there is mounting evidence that PPAR alpha activation can markedly reduce pre-existing retinopathy in type 2 diabetes, and more recently this has been confirmed also for type 1 diabetes. This is why the LENS study is so important. So what we know from standards of care, since the STENO2 study, we know that even if you apply the best of care for a long duration, more than 10 years, which means intensive glucose lowering, intensive blood pressure lowering, intensive dietary and lifestyle intervention, you are left with a more than 50% progression of diabetic retinopathy on top of other microvascular complications. So residual risk is always present in most of patients. We also know the limits of intensive glucose lowering since 2008 with the ACCORD trial, in which intensive glucose control of course reduced retinopathy progression by 33% relative and by an absolute risk reduction of 3%. But in that study, at least, there was excess mortality in the intensive glucose treatment group, the cause of which has never been fully established, but still these are the limits of intensive blood glucose control. We also know from the ACCORD trial that intensive blood pressure control does not deliver benefit. So we are left with continuing to improve glycemic control in our patients, and we have now better drugs to do that, but be careful because very powerful drugs such as GLP-1 receptor agonists can aggravate retinopathy because they are so powerful to start with in patients with poor baseline glycemic control. Blood pressure control does not deliver added benefit, and then we have those odd results from fenofibrate. It all started in the field study a long time ago, in which there was an unexpected improvement of retinopathy on patients following fenofibrate therapy. Then we had the ACCORD-I trial, which was a better designed study to assess the benefit of fenofibrate. Then we have almost 15 years without evidence except from a real-world evidence from South Korea, in which it was also confirmed that fenofibrate was effective. And then we have the LENS study, which I will talk more in detail. So let's look first at the field study. The field study was a large study in which almost 10,000 patients were randomized to be treated with fenofibrate or placebo at a time when statin therapy was not very widespread among type 2 diabetics. And in the field study, most patients who were put on fenofibrate did not have atherogenic dyslipidemia, meaning they had normal triglycerides. So in a way, it was a very odd design to get a PPAR alpha agonist to patients who did not require it. Anyway, the study was negative for the, not surprisingly, the study was negative for the cardiovascular outcome, but the study was actually strangely positive for secondary outcome. And patients who had been treated with fenofibrate during the field trial had much less requirement for laser treatment, be it a first laser therapy or any laser treatment. And the benefit was seen for all types of intervention for diabetic retinopathy. It was a large benefit, 30% risk reduction, even up to 50% reduction in laser treatment for patients. And what was unique for the field study, it was that the benefit was additional to blood pressure and glycemic control, and it was also unrelated to baseline lipids. So it was totally independent of lipid lowering, and it was achieved rapidly. And this has practical clinical consequences because the benefit was shown within 1 year of treatment, and it kept increasing over the 5-year study period. But again, the study was negative for the primary outcome, which was cardiovascular. The field study also showed other benefits on amputations that I will show you later. But because of that, there was a subgroup analysis of the ACCORD study called the ACCORD-I, which was a predefined study to look at the benefit of fenofibrate on retinopathy using a validated scale, which was the ETDRS progression scale of retinopathy. And again, there was a marked benefit over the study period of 40% reduction. The absolute risk reduction was even larger than with intensive glucose lowering, and the residual risk was still there, but to a lesser degree than after intensive blood glucose control. Very importantly, in that study, every single patient was on baseline statin therapy at inclusion. So that study corresponds better to the current standards of care for most type 2 diabetic patients. Interestingly, and that was a bit different from the field study, when subgroup analyses were done based on pre-existing retinopathy at baseline, it was shown that only patients with existing retinopathy benefited from fenofibrate in that study. Otherwise, the study showed the safety of fenofibrate, and as in the field study, the benefit was absolutely independent of baseline lipids or lipids lowering during the study period. Now, if you compare ACCORD-I, which is on top, 40% reductions with intensive glucose lowering in the ACCORD glucose arm, the benefit was even larger than for intensive glucose lowering. But again, it was only a one prospective study, so you cannot have guidelines changed based on that only, because you need at least 2 randomized trials to hope to have evidence to change the guidelines. Nothing's changed over a 13-year period. There was a very worthy real-world evidence registry study from South Korea, which analyzed a very large cohort, almost 1 million people with type 2 diabetes and metabolic syndrome. And they used that registry cohort over a 10-year period to see what happens when patients were put on fibrate on top of statin therapy. So after sorting out patients, they were left with 22,000 patients with a statin fenofibrate combination, and they were compared with almost 500,000 patients with statin only over the same period in a 1-to-2 propensity score matching. So it is an observation study, but interestingly, it showed almost the same benefit as in ACCORD. There was a 12% reduction over the whole study period. But if you divide patients according to a retinopathy at inclusion, it was only those patients in the solid lines who were put on fenofibrate plus statin who benefited, whereas patients in the dotted line who had no retinopathy at inclusion in the registry showed no benefit. Now, be careful, doesn't mean that there is no benefit, because if you don't have retinopathy at baseline, it could just be because your glucose control is always good, and you cannot even develop retinopathy in a long follow-up period. Also in that study, there was no heterogeneity of benefit according to major baseline characteristic, including lipids. So a confirmatory study. What about potential mechanism of action. We don't have mechanistic studies. We know from animal models and from human studies that there are PPAR-alpha receptors everywhere in the various eye tissue that could be involved in diabetic retinopathy. We know that PPAR-alpha activation can do at least 4 beneficial effects at the eye level. It can decrease neovascularization. It is an anti-inflammatory drug. It can also fight against retinal dysfunction and also decrease apoptosis. So these are potential mechanisms of the benefit. We have 2 animal models that further confirm the potential mechanism of benefit. In a diabetic rodent model, PPAR-alpha activation with fenofibrate decreases inflammation. That's a well-known effect in the whole body, but it's also demonstrated in the eye, and it also decreased vascular hyperpermeability. In an oxygen-induced retinopathy model, it also decreases ischemia and neovascularization. So these are just, mechanism of action. As I told you, if I go further away from the eye, the field study also shows some unexpected benefit on albuminuria, and that despite a functional increase in serum creatinine that everybody knows happens with fibrate, but we know from the field washout study that the drop in filtration is reversible and is associated with nephroprotection. Much more important, there was almost a 40% reduction in lower limb amputation in the field study. This was a non-primary outcome, even though for patients this would be a major outcome. And when looking at the type of amputations that were prevented by fenofibrate, these were mostly distal lower limb amputations, which are assumed to be microvascular damage rather than macrovascular damage. Again, the benefit was seen rather rapidly over time and kept increasing over time in the field study, but unfortunately that paper, despite being published in the Lancet, was quite overlooked by most diabetologists, which I find very sad because it was seen as a 3rd level outcome, but still it's a major outcome given the very few efficient therapy that we have for amputations. And then we have the LENS study, which was published last year. It's a major trial because it will add to the ACCORD-I trial what was lacking so far. It's a second prospective outcome trial on fenofibrate on diabetic retinopathy. The population this time included only patients with background retinopathy at baseline, based on the ACCORD-I data. It was useless to include patients without retinopathy at baseline, and they were randomized into fenofibrate or placebo after a run-in period on fibrate for 1 month. And the primary outcome was development of a referable diabetic retinopathy using a Scottish grading scale for retinopathy. In practice, it was a 2-step increase in retinopathy severity over time, and the study was statistically designed to keep going until enough primary outcome events had occurred, and the duration was at least 4 years in order to have time for those events to develop. The primary outcome, as I told you, was a composite of referable diabetic retinopathy or treatment for retinopathy, including laser, vitrectomy, or injections, intravitreal injections. There were a lot of secondary outcomes and tertiary outcomes. I will not go too much into them, but the part of the secondary outcomes were the components of the primary outcome, as often in those prospective CVOTs. This is the Scottish grading system that was used. It was a 5 or 6 grade for retinopathy, depending on whether you consider the no retinopathy as a grade, and there was a 3 grade for maculopathy. Patients were were comparable across randomization. There were more than 1,100 patients in the study, and they were mostly white males, but and this is unique to that study. In that study, more than a quarter of patients had type 1 diabetes, which was never addressed before in a prospective study on fenofibrate. You won't be surprised to see that diabetes duration was almost 20 years, which makes sense because those patients had to have retinopathy at entry. And they were mostly in a very mild background retinopathy called R number 1 in that Scottish grade system. And most 90% had no maculopathy at baseline. Patients were otherwise well matched for all the usual baseline characteristics, including lipids and glomerular filtration rate. Of interest, you had 3/4 of patients had normal filtration rate before the run-in period on fibrate, and only 2/3 only after the 1 year on fibrate as expected, and they were otherwise matched. Now, the paper on these were the baseline characteristics published in another journal. The effect of the result of the LENS study were published last year in an offshoot journal of the New England Journal of Medicine, aptly called Evidence. That's definitely what we need with fibrates. Effect of fenofibrate, and the study was markedly positive with a decrease of 27% with a rapid onset of benefit over time that almost slightly increased over time, but within 1 year the Kaplan-Meier started to diverge, and every type of component of the primary outcome was beneficially impacted. It was mostly a two-step progression on the retinopathy scale, but also macular edema and more severe form of ocular complications. Again, there was no heterogeneity of benefit regardless of age, gender, and most importantly, there was no interaction according to type of diabetes. So this is the first indirect evidence that the benefit may be as large in type 1 diabetes as in type 2. In this study, it may be slightly less, but still it's 22% relative reduction and almost 30% risk reduction in type 2 diabetes subgroup, which was the majority of patients. Also, the benefit was irrespective of HbA1c at baseline, and it was also irrespective of whether you look after 1 year of treatment or beyond the first year of treatment. So the benefit was obtained across the study period. Other variables of interest were those you expected: a slight drop in creatinine in GFR, a slight drop in triglycerides, and a slight drop also in albuminuria. So that was expected from the known effects of fibrates. So with that evidence, we now have 2 prospective randomized trials showing a large benefit on top of the effect of established standards of care. We don't have the slightest idea how it works. Fibrates are very complex drugs. PPAR alpha agonism has at least 30 different effects that may be ascribed as potentially beneficial to the eye. So as for many new drugs, we have a large benefit and no mechanism of explanation. Thank you.